The nutrients. So the body requires fuel to provide energy for cellular metabolism and repair, organ function, growth, and body movements. So the fundamental purpose of nutritional biochemistry research is to determine the ideal dietary and nutritional requirements of both healthy people and people who are sick. The discipline is also working on ways to lessen the negative effects of pharmacological medications, biochemical treatment saves lives, lower morbidity, improves health outcomes, and lowers health care expenditures. So the health advantages of eating organic fruits and vegetables are studied through nutritional biochemistry. So it concentrates on the chemical components of foods and how they work metabolically, physiologically, and biochemically. Science such as physics, chemistry, and biology are also used. It is particular nutrition techniques such as evaluation and intervention used to treat an ailment, injury, or disease. So the next is we have the macronutrients rather, are the nutrients we need in larger quantities that provide us with energy. So in other words, fats, protein, and carbohydrates. Micronutrients are mostly vitamins and minerals and are equally important but consumed in very small amounts. We generally get our micronutrients along with macronutrients, protein containing foods such as meat, beans, milk, fish, or eggs are sources of iron, calcium, and vitamin D. So for example, carbohydrates containing foods such as fruit and vegetables provide a wide range of vitamins. So minerals and fiber, while starchy carbohydrates such as brown rice, whole grains, bread, and cereals provide fiber B, vitamins, and magnesium. Fats provide us with vitamins A, D, E, and F. So the next is, what is carbohydrates? So carbohydrates composed of carbon, hydrogen, oxygen are the main source of energy in the diet. So each gram of carbohydrates produces a 4 kilogram, and serves as the main source of fuel, which is the glucose in the brain, skeletal muscle during exercise, erythrocyte and leukocyte production, and cell production of the renal medulla. So carbohydrates are found in the wide array of both healthy and unhealthy foods, such as bread, beans, milk, popcorn, potatoes, cookies, spaghetti, soft drinks, corn, and cherry pie. They also come in a variety of forms. The most common and abundant forms are sugars, fibers, and starches. So, naapod tayo simple carbohydrates. So, kaning simple carbohydrates are broken down quickly by the body to be used as energy. Simple carbohydrates are found naturally in foods such as fruits, milk, and milk products. They are also found in processed and refined sugar such as candy, table sugar, syrups, and soft drinks. So the majority of carbohydrates intake should come from complex carbohydrates. So muna siya mga starches, and naturally occurring sugars rather than processed or refined sugar. So simple carbohydrates is the classification of both monosaccharides and disaccharides. They are found primarily in sugar. So what is monosaccharides? So monosaccharides are the simplest form of carbohydrates that are easily absorbed in intestine compared to the disaccharides. So oligosaccharide and polysaccharide. So the monosaccharide consists of single unit which contains carbon chain of 3 to 6 carbon. So they combine through glycosidic bonds to form larger carbohydrates. So the main function of monosaccharide is to produce and store energy. So glucose and fructose are the most available in monosaccharide in nature. So, ang polysaccharide whose molecules consist of a number of sugar molecules bonded together. The body is unable to digest polysaccharide because we do not have enzymes capable of down breaking them down. So, the next is the proteins. So, proteins provide source of information, source of energy. So, nutrients are the compounds in foods that provide us with energy that facilitates repair and growth and helps to carry out different life processes. So, contribute to body structure and or regulate chemical processes in the body. So, mo to siya, no? Ang protein is the source of information or the source of our energy. So the next is amino acids. So amino acid consume and excess of the amount needed for the synthesis of nitrogenous tissues. Constituent are not stored but are degraded. So the nitrogen is excreted as a urea, and a keto acid left after removal of the amino groups are either utilized directly as sources of energy or converted to carbohydrates or fat. Mo na siyang amino acid. So the next is the nitrogen. So nitrogen balance means that the intake and output of nitrogen are equal. So when the intake of nitrogen is greater than the output, the body is in positive nitrogen balance. So mo to siya, no, sa nitrogen balance. So the next we have the fats. So fats are the most calorie dense nutrients, providing 9 kilogram. Fats are composed of triglycerides and fatty acids. So triglycerides are a type of fat called lipid. So that circulate in your body. They are most common type of fat in your body, which is ang lipids or triglycerides. Types of fat called lipids. So the next is triglycerides. So what is what is triglycerides? So come from foods, no? So foods, especially butter, oils, and other fats you eat. No, triglycerides also come from extra calories your body does not need right now. So fatty acids are the building blocks of the fat in our bodies and in the food we eat, no? The mga food nga itong ginakaon, diyan nato makuha ang triglycerides, such as mo to siya mga butter oils, no? And also yung katong mga fats, mga fatty foods. So during digestion, the body breaks down fats into fatty acids, which can be absorbed into the blood. So fatty acid molecules are usually joined together in groups of 3, forming a molecule called triglycerides. So next is let us proceed to the monounsaturated fatty acids or MUFAs. So are a type of unsaturated fat. Mono meaning one signifies that monounsaturated fats have only one double bond. So monounsaturated fats are healthy fats found in olive oil. So olive oil, such as mga avocados and certain nuts. In fact, the evidence shows that the monounsaturated fats have a number of health benefits. So remember that word, no? Monounsaturated fats have a number of health benefits. So they can help with weight loss, reduce the risk of heart disease, and decrease inflammation. Okay. So, muna ang monounsaturated fatty acids. Okay. So, the next is, let us proceed to the polyunsaturated fats, no? Which is can help to reduce bad cholesterol levels in your blood, which can lower your risk of heart disease and stroke. So, from a chemical standpoint, the polyunsaturated fats are simply fat molecules that have more than one unsaturated carbon bond in the molecule. So, this is called a double band. So, oils that contain polyunsaturated fats are typically liquid at room temperature but start to turn solid when chilled. So olive oil is an example of types of oil that contains a polyunsaturated fats. So as I've said earlier, nga ang kaning monounsaturated fatty acid is a mono meaning one bond lang yun siya. But it can also help to lower our risk of heart disease and of course ang stroke. So same thing sa polyunsaturated, but the difference is ang polyunsaturated fatty acid is double strand ang iyaha. Okay? No, it can also help us to lower our risk of heart disease and stroke. So mao to siya, no? So the next is let us proceed to the unsaturated fats, no, are an important supplies of calories and therefore energy to the most concentrated source of energy in food. So fats along with protein and carbohydrates are the three main nutrients present in food. So fats are categorized according to their percentage of hydrogen bonds as saturated. So all hydrogen bonds or unsaturated, not all hydrogen bonds. So mo to siya, no, ang unsaturated fats mo na siya ang energy to human body. So fats are made of carbon, hydrogen, and oxygen, and the most concentrated source of energy in food. So the next, let us proceed to the saturated fats. So what do you mean by saturated fat? What are the difference between the two? Unsaturated fats and saturated fat. So saturated fat, it is a fatty acid in which the hydrocarbon molecules have a hydrogen atom on every carbon and thus are fully hydrogenated. By the comparison, the hydrocarbon molecules of unsaturated fats have two carbons that share double or triple bonds, are therefore not completely saturated. So saturated fatty acid is a type of fatty acid that lacks unsaturated linkage between carbon atoms because of the lack of double bonds. So no, this type of fatty acid can no longer absorb anymore. So why? No, the question is why? Because ang saturated fatty acid mo na siya ang fatty acid ng lacks unsaturated linkage between sa carbon atoms, no? That is why, no, because of the lack of double bond, this may dili siya maka-absorb og fatty acids. Okay? So the next is we have the water. So water is critical because of cell function depends on a fluid environment. So water makes up 60% to 70% of total body weight. So no, water is essential for our body. It water makes 60 to 70% total weight. So imagine 60 to 70% how much it is a very essential good, no? So lean because muscle contains more water than obese people do blood. Okay, so now let us proceed to the next topic, which is the micronutrients. So kanina I mentioned it is a macro, not micro. It is a macronutrients ganina. Karon let us proceed to the micronutrients. So micronutrients often referred to as vitamins and minerals, are vital to healthy development, disease prevention, and well being. So, with the exemption of vitamin D, micronutrients are not produced in the body and must be derived from the diet. So, micronutrients are used for a huge range of different functions, and full of extent of their role is still being discovered. They are used in all the vital processes that the body carries out. For example, magnesium is used for electrolyte balance, energy yielding metabolism, and many other functions. So what that is the micronutrients, no? Referred to as vitamins and minerals. That is a micronutrients. So, the vital to healthy development. So, muna siya ang disease prevention and also sa atong well-being. No? So, the next is, this is the parts of the micronutrients, no? Such as minerals. So, minerals are naturally occurring inorganic elements or compound having an orderly internal structure and characteristic chemical composition, crystal form, and physical properties. So macrominerals are calcium, phosphorus, magnesium, sodium, potassium, and chloride, and sulfur. So now let us proceed to the vitamins. So vitamins helping to fight infection, no? A wound healing, making our bones strong and regulating hormones, no? Fat soluble vitamins are absorbed through the gut with the help of fat, so they can be stored in the liver and fatty tissue until the body needs them. So no, as we all know, the vitamins are the fight it help us to fight infection, no? Muna siya ang mag-fight sa infection, and also it is ang vitamins pod ang mag-help to regulate our hormones and of course making our bones strong. Okay?
Now let's proceed to the anatomy and physiology of digestive system. The digestive system includes the digestive tract and its accessory organs, which process food into molecules that can be absorbed and utilized by the cells of the body. Food is broken down bit by bit until the molecules are small enough to be absorbed and waste products are eliminated. The digestive tract, also called the alimentary canal or gastrointestinal tract, consists of a long continuous tube that extends from the mouth to the anus. Now the first organ is the oral cavity or mouth is the first portion of the digestive tract. It is composed of two separate regions, the vestibule and the area between cheeks, teeth, and lips, and the oral cavity proper. The main function of the mouth is to break up food particles and assist in producing language. The mouth not only plays a vital role in the initial intake and digestion of food and water, but also in essential for formation of speech and normal respiration. The teeth, which are the chief structure of the oral cavity, tear and grind ingested food into pieces small enough to digestion. The tongue enables the digestion of food through compressing and pressing food against the palates. This leads to the formation of the food bolus, subsequently swallowed down the esophagus. Next is the salivary glands. It is the mixed glandular secretion which constantly bats the teeth and the oral mucosa. It is constituted by the secretion of the three paired major salivary gland, the parotid, the submandibular, and the sublingual. The main function of salivary gland is to moisten and lubricates food. The presence of saliva is vital for the maintenance of healthy, hard, and soft oral tissues. Severe reduction of salivary output not only results in a rapid detrimental impact on the quality of life for the sufferer. Patients suffering from dry mouth can experience difficulty with eating, swallowing, speech, trauma to the ulceration of the oral mucosa, taste alteration, poor oral hygiene, and burning sensation of the mucosa and oral infection. Next is the pharynx, usually called the throat. It is a ring-like muscular tube that acts as the passageway for air, food, and liquid. It serves both the respiratory and digestive system by receiving air from the nasal cavity and air, food, and water from the oral cavity. Next is the esophagus. It is a hollow organ that is part of the gastrointestinal system, and it is responsible for function including the formation of chyme, synthesis of proteins necessary for vitamins absorption, microbial defenses, and propagates the peristaltic reflex. The stomach continues to break food down mechanically and chemically through chumming the food and secreting acid and enzymes for digestion. The gallbladder will serve to store and concentrate bile coming from the liver into the period between meals. Its primary function is to store and concentrate bile, a yellow-brown digestive enzymes produced by the liver. Next is the liver. It regulates most chemical level of the blood and excretes a product called bile. This helps carry away waste product from the liver. All the blood leaving the stomach and intestine passes through the liver. The liver processes this blood and breaks down, balances, and creates nutrients, and also metabolizes drugs into form that are easier to use for the rest of the body or that are non-toxic. Next is the pancreas. Has two essential and very important functions in the body: endocrine production of hormones that regulates blood sugar levels and glandular secretion, and the exocrine, which the function of the digestive gland. Next is the small intestine. Its primary function is to break down food, absorb nutrients, extract water, and move food along the gastrointestinal tract. It extracts excess water and sends the remaining food waste to the large intestine to be formed into a stool. So next is the large intestine. Has three primary functions: reabsorb water and electrolyte, producing and reabsorbing vitamins, and forming the propelling feces toward the rectum for elimination. Next is the rectum. It is the last step before the feces is eliminated through the anal canal. This will serve as a reservoir for fecal contents. It acts as a temporary storage site for feces. The last part is the anus. It is the end of the rectum. It's where stool comes out of the body. It consists of a muscular ring, which is called the sphincter, and they open during a bowel movement to allow stool or feces to pass through. And now let's proceed to the four major tasks of the digestive system. First is the digestion. Next is absorption. The third one is the metabolism and storage of nutrients. Lastly is the elimination. The digestive system ingest and digest food, absorb, release nutrients, and excrete food components that are ingestible. The main activities involved in this process are the following. First is digestion. It is the mechanical breakdown that results from chewing, chumming, and mixing the fluid and chemical reaction in which reduces to its simplest form. The longer an individual chews food, the more starch digestion occurs in the mouth. Chewing reduces food particles to a size suitable for swallowing, and saliva provides lubrication to ease swallowing of the food. Digestion begins in the mouth, where chewing mechanically break down food. The food mixes with saliva, which contain pyalin or salivary amylase and enzymes that act as cook starch to begin and conversion. The enzymes are the proteins-like substances that act as catalysts to speed up mechanical reaction, which are the essential part of the chemistry of digestion, and most of enzymes have one specific function. The enzyme's activity depends on the mechanical breakdown of food to increase the surface area for chemical action. Protein and fats are breakdown physically to remain unchanged chemically because enzymes in the mouth do not react with these nutrients. As the food leaves the antrum or distal stomach through the pyloric sphincter and enters the duodenum, food is now an acidic liquefied mass which is called chyme. The chyme flows into the duodenum and quickly mixes with bile, intestinal juice, and pancreatic secretion. Next is the absorption. The absorption of carbohydrates, protein, minerals, and soluble vitamins occur in the small intestine, and then processed in the liver and released into the portal vein circulation. The fatty acid absorbed in the lymphatic circulatory system through lacteal ducts of the center of each microvilli in the small intestine. Approximately 85% to 90% of water is absorbed in the small intestine. The gastrointestinal tract manages approximately 8.5 liter of gastrointestinal secretion and the 1.5 liter approximately of gastrointestinal of oral intake daily. So the small intestine reabsorbed the 9.5 liter and the colon absorbed approximately 0.4 liter. The elimination of the remaining is 0.1 liter occurs via feces. So there are mechanisms for intestinal absorption of the nutrients. First is the active transport. It is an energy-dependent process whereby particles move from the area of greater concentration to an area of a lesser concentration. Next is the passive transport, the force by which particles move outward from an area of greater concentration to one of lesser concentration. The next is the osmosis. It is the movement of water through the semi-permeable membrane that separates solution of different concentration. The next is the pinocytosis, engulfing of large molecules of nutrients by the absorbing cell when molecules attaches to the absorbing cell membrane. The next task is the metabolism and storage of nutrients. Metabolism refers to all of the biochemical reaction within the cell of the body. Metabolic processes are anabolic or building, or catabolic, which is the breakdown. The anabolism is the building of more complex biochemical substances by synthesis of nutrients. It occurs when the individual adds lean muscle through diet and exercise. Next is the catabolism. It is the breakdown of biochemical substances into simpler substances and occur during psychological states of negative nitrogen balance. Starvation is one of the examples of catabolism when wasting of the body tissues occurs. Some of the nutrients required in the body are stored into tissues. In the tissues, the major form of body reverse energy is fat stored as adipose tissue. So the nutrients metabolism consists of three main processes. First is the catabolism of glycogen into glucose, carbon dioxide, and water, also known as the glycogenolysis. Next is the anabolism of glucose into glycogen for storage, also known as the glycogenesis. Then lastly is the catabolism of amino acid and glycerol into glucose for energy, which is known for gluconeogenesis. Then the last task of digestive system is the elimination. It is the water absorbed in the mucosa as feces move toward the rectum. The longer the material stays in the large intestine, the more water is absorbed, causing the feces to become firmer.
So, dietary guidelines. So, dietary reference intakes. So, it presents evidence-based criteria for an acceptable range of amounts of vitamins and nutrients for each gender and age group. So, there are four components to the dietary reference intakes. So, first is the estimated average reference. So, it is the suggested amount of nutrients sufficient according to age and gender to maintain a particular bodily function for 50% of the population. So, the second is the recommended dietary allowance. So, it is the average needs of 98% of the population, not the exact needs of an individual. So, third is adequate intake. So, it is suggested intake for individuals based on observed or experimentally determined estimates of nutrient intake and use when there is not enough evidence to set the RDA. So, the fourth is upper intake level. So, it is the highest level that likely possess no risk or of adverse health events. So, it is not a recommended level of intake. So, let's proceed to food guidelines. So, the U.S. Department of Health and Human Services and the U.S. Department of Agriculture published the dietary guidelines for American. So, it published on 2015 to 2020. So, provide average daily consumption guidelines for the five groups. So, it is the grains, vegetables, fruits, dairy milks, and meats. So, as a nurse, consider the food preferences of patients from different cultural groups, vegetarians, and other when planning diets. So, the U.S. Department of Agriculture developed the Choose My Plate program to replace the My Food Pyramid program. So, gi-replace nila ang My Food Pyramid program. So, daily values. So, the U.S. Food and Drug Administration created daily values for food labels in response to the 1990 Nutrition Labeling and Education Act. So, the FDA first established two sets of reference values. So, the reference daily intakes are the first set comprising protein, vitamins, and minerals based on the RDA. So, the daily reference values make up the second set and consist of nutrients such as the total fat, saturated fat, cholesterol, carbohydrates, fiber, sodium, and potassium. So, combined, both sets make up the daily values used on food labels. So, daily values did not replace the RDAs, but provided a separate, more understandable format for the public. So, daily values are based on percentages of a diet consisting of 2,000 calories per day for adults and the children for 4 years or older. So, let's proceed to factors influencing instruments. So, environmental factors. So, beyond the control or individuals contribute to the development of obesity, proposed contributing factors for obesity are sedentary lifestyle. So, work schedules and poor meal choices often related to the increasing frequency of eating away from home and eating fast food. So, it can limit a person's livelihood of healthy eating and participation of exercise or other activities of healthy living. So, second is developmental needs. So, infants through school age. So, rapid growth and high protein, vitamin, mineral, and energy requirements mark the developmental stage of infancy. Average birth weight of American baby is 7.5 pounds to 3.4 kilogram. So, an infant usually doubles birth weight at 4 to 5 months and triples it at 1 year. So, infants need an energy intake of approximately 90 to 110 calcium or kilogram of body weight per day. So with premature infants needing 105 to 130 calcium or kilogram per day. So breastfeeding. So it can help protect babies against some short and long-term illnesses and disease. So breastfed babies have lower risk of asthma, obesity, type 1 diabetes, and sudden infant death syndrome. So breastfed babies are also less likely to have an ear infection and stomach bugs. So formula. So the formula contain the approximate nutrient composition of human milk. So protein in the formula is typically whey, soy, cow's milk base, casein hydrolysate, or elemental amino acids. So infants with allergies or intolerant to cow's milk should consume soy protein-based formula instead. Infants should not have regular cow's milk during the first year of life. So it is too concentrated for an infant's kidney to manage, increases the risk of milk product allergies, and is a poor source of iron, and age should never ingest honey and corn syrups products because they are potential sources of bot, botulism toxin, which increases the risk of infant death. So, introduction to solid food. So, by around 4 to 6 months, babies need to start having solid food. Introducing solids is also important for helping babies learn to eat, giving them experience of new taste and texture from a range of foods. So, it develops their teeth and jaws, and it builds other skills that they'll need later for language development. So, adolescence. So, during adolescence, physiological age is a better guide to nutritional needs than chronological age. So, energy needs increase to meet greater metabolic demands of growth. So, daily requirement of protein also increases. Calcium is essential for the rapid bone growth of adolescents, and girls need a continuous source of iron to replace menstrual losses. So boys also need adequate iron for muscle development. So adolescents represent the well-being of a society and its development potential, and food and good health helps ensure independence, security, and productivity across the life course. Young and middle adults. So during this stage, middle-aged adults begin contributing to the next generation, often through caring for others. They also engage in meaningful and productive work that contributes positively to society. So pregnancy. So pregnancy, poor nutrition during pregnancy causes low birth weight in infants and decreases chances of survival. So generally, meeting the needs of a fetus is at the expense of the mother. However, if nutrient sources are not available, both suffer. So getting good care before, during, and after your pregnancy is very, very important. It can help your baby grow and develop and keep you both healthy. So folic acid intake is particularly important for DNA synthesis and the growth of red blood cells. So inadequate intake can lead to fetal neural tube defects, anencephaly, or maternal megaloblastic anemia. So women of childbearing age need to consume 400 of folic acid daily. So increasing 600 daily during pregnancy. So prenatal care can help prevent complications and inform women about important steps they can take to protect their infant and ensure a healthy pregnancy. So the last is the older adults. So older adults decreased need for energy because their metabolic rate slows with age. However, vitamin and mineral requirements remain unchanged from middle adulthood. So maintaining good oral health is significant throughout adulthood, particularly as an individual ages. So that's all, and thank you for listening.
Now I'll be discussing the factors affecting nutritional status. So there are several factors that can affect nutritional status. The following are age, presence of chronic illnesses, adequate nutrition in older adults, adverse effects of medication, and cognitive impairment. So first, for the age-related gastrointestinal changes can affect digestion of food and maintenance of nutrition, including changes in teeth and gums, reduced saliva production, and decreased esophageal and colonic peristalsis. So an example of this is in the case of older adults. So as people age, their body composition changes with a decrease in muscle mass and an increase in fat mass. This change in body composition can lead to a decrease in appetite and a change in taste preferences, making it difficult for older adults to obtain the necessary nutrients from their diet. In addition, older adults may have difficulty chewing or swallowing, leading to a decrease in food intake. Older adults may also have a limited income and may prioritize other expenses over purchasing healthy foods, leading to a poor diet. All of these factors can contribute to a malnutrition in older adults. So next is the presence of chronic illnesses such as diabetes, end-stage renal disease, or cancer can also negatively affect nutrition intake. So an example of this is like how it affects nutritional status is in the case of a person with inflammatory bowel disease, people with or IBD. So people with IBD often experience symptoms such as abdominal pain, diarrhea, and nausea, which can make it difficult to consume and digest food. Additionally, the chronic inflammatory nature of the disease can cause malabsorption of nutrients, leading to deficiencies in key vitamins and minerals. This can also impact the person's appetite, as well as their ability to maintain a healthy weight. As a result of these factors, individuals with IBD may require specialized diets or nutritional supplements to manage their condition and maintain their health. So next is the adequate nutrition in older adults is affected by multiple causes like lifelong eating habits, culture, income, and physical functional level. The next is the adverse effects of medications, which can cause issues like gastrointestinal bleeding, xerostomia, early satiety, and impaired taste perception. So for this, an example of this, like how adverse effects of medication can affect the nutritional status is in the case of a person taking anti-seizure medications. Some of these medications may cause decreased appetite, nausea, vomiting, and diarrhea, which can result in inadequate nutrient intake and malnutrition. So with these medications, they may interact with other nutrients and medications, leading to deficiency or toxicity of certain vitamins and minerals. For instance, some anti-seizure medications may interfere with the absorption of vitamin D and calcium, which can lead to bone loss and increase the risk of fractures. As a result, people taking anti-seizure medications may need to adjust their diet or take nutritional supplements to maintain their nutritional status. And lastly, the cognitive impairments such as delirium, dementia, and depression can also affect one's ability to obtain and prepare healthy foods. So it was mentioned that a person with dementia can affect their nutrition. So in this case, individuals with dementia may experience problems with memory, reasoning, and decision making, which can impact their ability to plan and prepare meals, shop for groceries, and manage their diet. They may forget to eat, skip meals, or become confused about what foods to eat and when to eat them. In addition, some individuals with dementia may experience changes in taste and smell, which can impact their food preferences and make it more challenging to eat a balanced diet. As a result, individuals with dementia may require assistance with meal planning
and preparation, as well as specialized diets or supplements to ensure that they are meeting their nutritional needs. So here we have an icebreaker question. So the question is, what are some factors that can negatively impact our nutritional status? A. Age-related gastrointestinal changes and chronic illnesses only. B. Lifelong eating habits, culture, income, and physical functional level only. C. Adverse effects of medications and cognitive impairments only. Or D. All of the above. So the answer is D. All of the above. So now let's proceed to the diagnostic criteria for eating disorder. So there are two, the anorexia nervosa and bulimia nervosa. So first, for the anorexia nervosa, the diagnostic criteria for this include restriction of energy intake, leading to significantly low body weight relative to age, sex, and physical health, intense fear of gaining weight or persistent behavior that interferes with weight gain, and a disturbance in the way one perceives their body weight or shape. This can include an undue influence of body weight or shape on self-evaluation or a persistent lack of recognition of the seriousness of their low body weight. So, for example, a person may claim to feel fat even when emaciated or believe that a specific area of their body is too fat, even when obviously underweight. So, the image shows what anorexia nervosa is. So next is bulimia nervosa. So the diagnostic criteria for bulimia nervosa include recurrent episodes of binge eating, which involve rapid consumption of a large amount of food in a discrete period of time, accompanied by a feeling of lack of control over eating behavior during the binges. The person also engages in recurrent inappropriate compensatory behaviors to prevent weight gain, such as self-induced vomiting, use of laxatives or diuretics, strict dieting or fasting, or vigorous exercise. These binge eating and inappropriate compensatory behaviors occur, and on average, at least once a week for 3 months. Additionally, the person's self-evaluation is unduly influenced by their body shape and weight. So the image on the right side shows what bulimia nervosa is. So another icebreaker question. The question is, what are some differences between anorexia nervosa and bulimia nervosa? A. Anorexia nervosa involves purging behaviors, while bulimia nervosa does not. B. Bulimia nervosa involves binge eating followed by purging behaviors, while anorexia nervosa does not. C. Anorexia nervosa and bulimia nervosa have the same symptoms and behaviors. Or D. Anorexia nervosa and bulimia nervosa are not real disorders. So the answer is bulimia nervosa involves binge eating followed by purging behaviors, while anorexia nervosa does not. So now let's proceed to alternative food pattern. So a vegetarian diet is a dietary pattern that consists mainly of plant foods. There are different types of vegetarians such as ovo-lacto-vegetarian, lacto-vegetarian, and vegan, depending on what animal product they exclude from their diet. With careful selection of foods, individuals following a vegetarian diet can meet their protein and essential nutrient requirements. However, diets such as Zen macrobiotic and fruitarian diets may be nutrient poor and result in malnutrition. It's important to have knowledge related to complementary use of high and low biological value proteins to ensure a balanced diet. Children following a vegetarian diet are especially at risk for protein and vitamin deficiencies, such as vitamin B12. Therefore, careful planning is necessary to ensure a balanced, healthy diet. So again, an icebreaker question. What are some considerations when following a vegetarian diet? A. Only certain types of vegetarians can meet their essential nutrient requirements. B. Zen macrobiotic and fruitarian diets are highly nutritious. C. Complementary use of high and low biological value proteins is not important on a vegetarian diet. And D. Children following a vegetarian diet may be at risk for protein and vitamin deficiencies. So the answer is D. Children following a vegetarian diet may be at risk for protein and vitamin deficiencies.
So let us now proceed for the sample of drug-nutrient interactions. This table represents the sample of drug-nutrient interactions, its drug and effect. Of course, the first one is the analgesic. It is also known as the painkiller. So there are two types, the acetaminophen and the aspirin. So the effects of the acetaminophen, it decreased the drug absorption with food overdose associated with liver failure. And the aspirin, it absorbed directly through stomach. So it decreased the drug's absorption with food, decreased folic acid, vitamin C, K, and iron absorption. Another drug is the antacid. This medicine counteracts or neutralizes the acid in your tummy or stomach. So it is also to relieve indigestion and heartburn. So under the antacid, there are aluminum hydroxide, which decrease the phosphate absorption, and the sodium bicarbonate, which decrease the folic acid absorption. Proceeding, it is now the antiarrhythmic drug. So this drug prevents and treats abnormal heartbeats or the arrhythmias. So there are two types, which are the amlodipine, its effect is the taste alteration, and the digitalis, its effect is the anoporexia, decreased renal clearance in older people. Next is the antibiotics. It is a medicine that fights bacterial infections in people and animals. So there are five subcategories on the antibiotic. The first one is the penicillin. Its effect is to decrease drug absorption with food and taste alteration. Is the cephalosporin. Its effect is to decrease the vitamin K. The rifampin or the Refedin, its effect is to decrease the vitamin B6, niacin, and vitamin D. The fourth is the tetracycline. Its effect is to decrease drug absorption with milk and antacids. Also to decrease nutrition absorption of calcium, riboflavin, vitamin C caused by binding. The fifth is the trimethoprim or the sulfamethoxazole. Its effect is to decrease the folic acid. Another drug is the anticoagulant, warfarin, acts as the antagonist to vitamin K. Next is the anticonvulsant. It's two subcategories, the carbamazepine or the Telgetol. Its effect is to increase drug absorption with food. The phenytoin or dilantin, so its effect is to decrease calcium absorption, decrease vitamins D and K, and folic acid. Taste alteration, decrease drug absorption with food. Let us proceed to the antidepressant. So there are three subcategories, such as amitriptyline. Its effect is the appetite stimulant. The clomipramine or the anafranil. Its effect is taste alteration, appetite stimulant. The third is the fluoxetine or the Prozac, selective steroid reuptake inhibitors or the SSRIs. Also, its effects is the same, the taste alteration and the appetite stimulant. The antihypertensive, of course, this is another drug. So there are four subcategories. The captopril or the Capoten. So it its effect is the taste alteration or anorexia. The second one is the hydrolysine, so it enhanced drug absorption with food and decreased vitamin B. The third is the labetalol or the normodine. So its effect is the taste alteration, so weight gain for all beta blockers. And then the fourth one is the methyldopa. So its effect is to decrease vitamin B12, folic acid, and iron. So proceeding to the anti-inflammatory drug, so all steroids. Its effect is to increase appetite and weight, increase folic acid, and decrease calcium, such as osteoporosis with long-term use. So it also promotes gluconeogenesis of protein. So the next is the anti-Parkinson's or the levodopa or the PAR. So its effect is the taste alteration, decreased vitamin B6, and drug absorption with food. So another drug is the antipsychotic. So there are two subcategories. The chlorpromazine, so its effect is increased appetite. And then the second one is the thyroxine, so its effect is to decrease riboflavin and increase needs. So let us now proceed to the bronchodilator. So also there are two subcategories. So the albuterol sulfate, so the effect appetite stimulant. Then the theophylline is the effect of it is the anorexia. So let us proceed to the next drug, the cholesterol lowering or the cholestyramine or the Prevalite. So its effect is to decrease the fat-soluble vitamins such as A, D, E, K, vitamin B12, and iron. The next one is the diuretic. So the first one is the furosemide or the Lasix. So its effect is decreased drug absorption with food. So the second one is the spironolactone or the alactone. So its effect is to increase drug absorption with food. And then the third one is the thiazides. So the effect decreased magnesium, zinc, and potassium. Proceeding to the next drug, the laxative mineral oil. So it decreased absorption of fat soluble vitamins such as A, D, E, K, and carotene. Proceeding, the platelet aggregate inhibitor or the pyridamol persentine decreased drug absorption with food. The next, potassium replacement or the potassium chloride. It decreases the vitamin B12. And then the next, the tranquilizer, and been called benzodiazepines or increased appetite.
Hello, good day. In this video, I'll be tackling about the nursing process in nutrition. And this includes the assessment, of course, and the nursing diagnosis and their subtopics. Nursing process in nutrition. Apply the nursing process and use a critical thinking approach in your care of patients. The nursing process provides a clinical decision-making approach for you to develop and implement an individualized plan of care. During the assessment process, thoroughly assess each patient and critically analyze findings to ensure that you make patient-centered clinical decisions required for safe nursing care. As we all know, early recognition of malnourished or at-risk patients have a strong positive influence on both short and long-term health outcomes. Studies demonstrate a link between malnutrition in adult hospitalized patients and readmission rates, higher mortality rates, and increased costs, in which patients who are malnourished on admission are at greater risk of life-threatening complications such as arrhythmia, sepsis, or hemorrhage during hospitalization. For the assessment, we have the screening. Nutrition screening is an essential part of an initial assessment. Screening a patient is a quick method of identifying malnutrition or risk of malnutrition using simple tools. Nutrition screening tools gather data on the current condition, stability of the condition, assessment of whether it will worsen, and if the disease process accelerates. These tools typically include objective measures such as height, weight change, primary diagnosis, and the presence of other comorbidities. Combine multiple objective measures with subjective measures related to nutrition to adequately screen for nutritional problems. Identification of risk factors such as unintentional weight loss, presence of a modified diet, or the presence of altered nutritional symptoms like nausea, vomiting, diarrhea, and constipation requires nutritional consultation. Several standardized nutritional screening tools are available for use in outpatient and inpatient settings. The subjective global assessment uses the patient history, weight, and physical assessment data to assess nutritional status. The SGA is a simple, inexpensive technique that is able to predict nutrition-related complications. The mini nutritional assessment screens older adults in home care programs, nursing homes, and hospitals. The tool has 18 items divided into screening and assessment. If a patient scores 11 or less on the screening part, the healthcare provider completes the assessment part. A total score of less than 17 indicates protein energy malnutrition. So in conclusion, malnutrition screening tools are an effective way to measure nutritional problems for patients in a variety of healthcare settings. So we need to assess patients for malnutrition when they have conditions that interfere with their ability to ingest, digest, or absorb adequate nutrients. Use standardized tools to assess nutrition risk when possible. Congenital anomalies and surgical revisions of the GI tract interfere with normal function. Patients receiving only an IV infusion of 5% or 10% dextrose are at risk for nutritional deficiencies, while chronic diseases or increased metabolic requirements are risk factors for development of nutritional problems. Infants and older adults are great risk for. Next is anthropometry. Is a measurement systems of the size and makeup of the body. Nurses obtain height and weight for each patient on hospital admissions or entry into any healthcare setting. If you are not able to measure height with the patient standing, position him or her lying flat in bed as straight as possible with arms folded on the chest and measure him or her lengthwise. Serial measures of weight over time provide more useful information than one measurement. Weight the patient at the same time each day, on the same scale and with the same type of clothing or linen. And then document the patient's actual weight and compare height and weight to standards for height-weight relationships. Ideal body weight. An ideal body weight provides an estimate of what a person should weigh. Rapid weight gain or loss is important to note because it usually reflects fluid shifts. 1 pint or 500 ml of liquid equals 1 lb or 0.45 kg. For example, for a patient with renal failure, a weight increase of 2 lbs or 0.90 kg in 24 hours is significant because it usually indicates that the patient has retained 1 liter or 1000 ml of liquid. Other anthropometric measurements often obtained by RDs help identify nutritional problems. This includes the ratio of height to wrist circumference, mid-upper arm circumference, triceps skin fold, and mid-upper arm muscle circumference. An RD compares values for MAC, TSF, and MAMC to standards and calculates them as a percentage of the standard. Changes in values for an individual over time are of greater significance than isolated measurements. Body Mass Index. BMI measures weight corrected for height and serves as an alternative to traditional height-weight relationships. Calculate BMI by dividing a patient's weight in kilograms by height in meters squared. Weight kilogram divided by height meters squared. For example, a patient who weighs 165 lbs or 75 kg and is 1.8 meter, 5 feet or 9 inches tall has a BMI of 23.15. So 75 divided by 1.8 is equals to 23.15. A patient is overweight if his or her BMI is 25 to 30. Obesity defined by a BMI of greater than 30 places a patient at higher medical risk for coronary heart diseases, some cancers, DM, and hypertension. Next is laboratory and biochemical test. No single laboratory or biochemical test is diagnostic for malnutrition. Factors that frequently alter test results include fluid balance, liver function, kidney function, and the presence of disease. Common laboratory tests used to study nutritional status include measures of plasma proteins such as albumin, transferrin, prealbumin, retinol binding protein, total iron binding capacity, and hemoglobin. After feeding, the response time for changes in these proteins ranges from hours to weeks. The metabolic half-life of albumin is 21 days. Transferrin is 8 days, prealbumin is 2 days, and retinol binding protein is 12 hours. Now, use this information to determine the most effective measure of plasma proteins for your patients. Factors that affect serum albumin levels include hydration, hemorrhage, renal or hepatic disease, large amounts of drainage from wounds, drains, burns, or the GI tract, steroid administration, exogenous albumin infusions, age and trauma, burn, stress, or surgery. Albumin level is a better indicator for chronic illness, whereas prealbumin level is preferred for acute conditions. Nitrogen balance is important in determining serum protein status. Calculate nitrogen balance by dividing 6.25 into the total grams of protein ingested in a day or for 24 hours. And use laboratory analysis of a 24-hour urine urea nitrogen or UUN to determine nitrogen output. For patients with diarrhea or fistula drainage, estimate a further addition of 2 or 4 grams of nitrogen output. Then calculate nitrogen balance by subtracting the nitrogen output from the nitrogen intake. A positive 2 to 3 grams nitrogen balance is necessary for anabolism. By contrast, negative nitrogen balance is present when catabolic states exist. Diet history and health history. In addition to the general nursing history, use data from a more specific diet history to assess a patient's actual or potential nutritional needs. The diet history focuses on the patient's habitual intake of foods and liquids and includes information about preferences, allergies, and other relevant areas such as the patient's ability to obtain food. Gather information about the patient's illness or activity level to determine energy needs and compare food intake. Your nursing assessment of nutrition includes health status, age, cultural background, religious food patterns, socioeconomic status, personal food preferences, psychological factors, use of alcohol or illegal drugs, use of vitamin, mineral or herbal supplements, prescription of over-the-counter drugs, and the patient's general nutrition knowledge. In an outpatient setting, have a patient keep a 3 to 7 day food diary. This allows you to calculate nutritional intake and compare it with DRI to see if the patient's dietary habits are adequate. Use food questionnaires to establish patterns over time. In healthcare setting, nurses collaborate with RDs to complete calorie counts for patients. Next, physical examination. The physical examination is one of the most important aspects of a nutritional assessment. Because improper nutrition affects all body systems, observe for malnutrition during physical assessment. Complete the general physical assessment of body systems and recheck relevant areas to evaluate a patient's nutritional status. The clinical signs of nutritional status serves as guidelines for observation during physical assessment. And lastly is dysphagia. Dysphagia refers to difficulty swallowing. The causes and complications of dysphagia vary. Complications include aspiration pneumonia, dehydration, decreased nutritional status, and weight loss. Dysphagia leads to disability or decreased functional status, increased length of stay and cost of care, increased likelihood of discharge to institutionalized care, and increased mortality. Now be aware of warning signs for dysphagia. They include cough during eating, change in voice tone or quality after swallowing, abnormal movements of the mouth, tongue, or lips, and slow, weak, imprecise, or uncoordinated speech. Abnormal gag, delayed swallowing, incomplete oral clearance or pocketing, regurgitation, pharyngeal pooling, delayed or absent trigger of swallow, and inability to speak consistently are other signs of dysphagia. Patients with dysphagia often do not show overt signs such as coughing when food enters the airway. Silent aspiration is aspiration that occurs in patients with neurological problems that lead to decreased sensation. It often occurs without a cough, and symptoms usually do not appear for 24 hours. Silent aspiration accounts for most of the 51% to 78% of aspiration in patients with dysphagia following stroke. Dysphagia often leads to an inadequate amount of food intake, which results in malnutrition. Frequently, patients with dysphagia become frustrated with eating and show changes in skin fold thickness and albumin. During the rehabilitation period, patients experience longer adjustment periods regarding new dietary restrictions. Furthermore, malnutrition significantly slows swallowing, recovery, and may increase mortality. We are now done with the nursing assessment, so we will proceed to the nursing diagnosis. For the nursing diagnosis, we have the clustering data, select appropriate related factors, risk nursing diagnosis, and needs defining characteristics. Clustering data. Cluster all assessment data to identify appropriate nursing diagnosis. A nutritional problem occurs when overall intake is significantly decreased or increased, or when one or more nutrients are not ingested, completely digested, or completely absorbed. Next is select appropriate related factors. When identifying a problem-focused nursing diagnosis, you select the appropriate related factors. Examples are inability to digest food or reduced daily activity. Related factors need to be accurate, so you select the right interventions. For example, imbalanced nutrition, less than body requirements related to economic disadvantage will require very different interventions than imbalanced nutrition, less than body requirements related to an inability to ingest food. Risk nursing diagnosis. A patient will have a risk nursing diagnosis when assessment reveals risk factors. For example, risk for overweight can be identified by the presence of risk factors such as excessive alcohol consumption or high frequency of eating restaurant food and adult BMI approaching 25 kg meter squared. Be specific so you can direct interventions toward risk factors. And then lastly is defining characteristics. Defining characteristics may also point to a health promotion diagnosis such as a readiness for enhanced nutrition. The following are nursing diagnoses applicable to nutritional problems: risk for aspiration, diarrhea, overweight, imbalanced nutrition or less than body requirements, readiness for enhanced nutrition, feeding self-care deficit, impaired swallowing, and obesity. In addition, there are clinical situations in which patients have multiple related nursing diagnoses. So that's all for this topic, the nursing assessment and nursing diagnosis in nutrition. I am Aliyah Villavelle Tutana from BSN1N1. Thank you.
To continue the previous reporter's topic, we will proceed with the next. So for this topic outline, we will have planning, implementation, and evaluation as well as their subtopics. So the first topic that we will tackle first is planning. Planning to maintain patient's optimal nutritional status requires a higher level of care than simply correcting nutritional problems. Often, there is a need for patients to make long-term changes for nutrition to improve. Synthesis of patient information from multiple sources is necessary to create an individualized approach of care that is relevant to a patient's needs and situation. Therefore, We will apply critical thinking to ensure that you consider all data sources in developing a patient's plan of care. The accurate identification of nursing diagnosis related to patients' nutritional problems results in a care plan that is relevant and appropriate. So first is goals and outcomes. Goals and outcomes of care reflect a patient's physiological, therapeutic, and individualized needs. Patients on therapeutic diets need to understand the implications of their diets and how prescribed diets help to control their illnesses. When planning care, be aware of all factors that influence a patient's food intake. For example, patients with heart failure experience decreased hunger, dietary restrictions, fatigue, shortness of breath, and sadness, which influence their food intake. Individualized planning is very essential. So, explore patients' feelings about their weight and diet and help them set realistic and achievable goals. Mutually planned goals negotiated among the patient, RD, and nurse ensure success. Meeting nutritional goals requires input from the patient and the multidisciplinary team, and knowledge of the role of each discipline in providing nutrition support is necessary to maximize nutritional outcomes. An effective plan of care, of course, requires accurate exchange of information among disciplines. To proceed is setting priorities. After identifying patient's nursing diagnosis, you determine priorities in order to plan timely and successful interventions. So, for example, managing a patient's oral pain will be a priority over the diagnosis of imbalanced nutrition, less than body requirements if the patient is unable to swallow and maintain adequate food intake. The priority for the resumption of food intake after surgery depends on the return of bowel function, the extent of the surgical procedure, and the presence of any complications. For example, when the patients have oral and throat surgery, they chew and swallow food in the presence of excision sites, sutures, or tissue manipulated during surgery. The priority of care is to first provide comfort and pain control, then address nutritional priorities and plan of care to maintain nutrition that does not cause pain or injury to the healing tissues. Patient and family must collaborate with the nurse in planning care and setting such priorities. This is important because food preferences, food purchases, and preparation involves the entire family. The plan of care cannot succeed without their commitment to or involvement in and understanding of the nutritional priorities. After planning is implementation. In diet therapies are numerous and are chosen on the basis of a patient's overall health status, ability to eat and digest normally, and long-term nutritional needs. In acute care, your role as a nurse is to manage acute conditions that alter patients' nutritional status and assist in a way to promote their appetite and ability to take in nutrients. Patients who are ill or debilitated often have poor appetites or anorexia. Anorexia or poor appetites has many causes. For example, pain, fatigue, and the effects of medication. Help patients understand the factors that cause anorexia and use creative approaches to stimulate appetite. In the restorative care setting, you will help patients learn how to follow the therapeutic diets necessary for recovery and treatment of chronic health conditions. Health promotion. The focus of health promotion is to educate patients and family caregivers about balanced nutrition and to assist them in obtaining resources to eat high-quality meals. Incorporating knowledge of nutrition into patients' lifestyles serves to prevent the development of many diseases. As a nurse, you are in a key position to educate patients about healthy diet choices and good nutrition. And your role as an educator includes assessing the patient's and family's health literacy and providing nutritional education and information about community resources. In addition, choose specific foods on the basis of the dietary prescription and recommended food groups. Support individuals who are interested in losing weight. Diet and exercise compliance affects the success with weight loss. Help patients develop a successful weight loss plan that considers their preferences and resources and includes awareness of portion sizes and knowledge of energy content of food. Moreover, food safety is an important public health issue. Foodborne bacteria can occur from improper food cleaning, preparation, or poor hygiene practices of food workers. Therefore, healthcare professionals not only need to educate patients, family, and community about nutrition and healthy diet, but also be aware of the factors related to food safety and provide patient education to reduce the risk of foodborne illnesses. Acute care. The nutritional care of acute ill patients requires a nurse to consider a variety of factors that influence nutritional intake. It is because diagnostic testing and procedures in the acute care settings disrupt food intake. Often, a patient must refrain from eating or drinking anything by the mouth or NPO as he or she prepares for or recovers from a diagnostic test. Mealtimes in a healthcare setting are frequently interrupted or patients have poor appetites. Patients often are too fatigued or uncomfortable to eat. It is important to continuously assess a patient's nutritional status and adopt interventions that promote normal intake, digestion, and metabolism of nutrients. So, for acute care in advancing diets, acute and chronic conditions affect a patient's immune system and nutritional status. Patients with decreased immune function, for example, cancer, chemotherapy, human immunodeficiency virus, or acquired immunodeficiency syndrome, or HIV/AIDS, or organ transplants. So, patients with decreased immune function, such as them, require special diets that decrease their exposure to microorganisms and are higher in selected nutrients. In addition, patients who are ill, who have had surgical procedures, or who were NPO for a period of time have specialized dietary needs. So, healthcare providers order a gradual progression of dietary intake or therapeutic diet to manage patients' illness. In acute care of promoting appetite, providing an environment that promotes nutritional intake includes keeping a patient's environment free of odors, providing oral hygiene as needed to remove unpleasant tastes, and maintaining patient comfort. Offering smaller or more frequent meals often helps. In addition, certain medications affect dietary intake and nutrient use. The nurse and RD help patients to select foods that reduce the altered taste, sensations, or nausea. Therefore, consult with an RD regarding seasonings that may be used to improve food taste. In addition, mealtime is usually a social activity. If appropriate, encourage visitors to eat with the patient. When patients experience anorexia, encourage other nurses or care providers to converse and engage them in a conversation. Mealtime is also an excellent opportunity for patient education. Instruct a patient about any therapeutic diets, medications, energy conservation measures, or adaptive devices to assist with independent feeding. So, for acute care of assisting patients with oral feeding. So, when a patient needs help with eating, it is important to protect his or her safety, independence, and dignity. With the help of an SLP or speech language pathologist, determine the viscosity of foods that the patient tolerates best through the use of trials of different consistencies of foods and fluids. However, thicker fluids are generally easier to swallow. So, in assisting patients with oral feeding, first is we have to clear the table or overbed tray of clutter. Next is to assess his or her risk of aspiration, since patients at high risk for aspiration have decreased level of alertness, decreased gag and cough reflexes, and difficulty managing saliva. Next, Provide a 30-minute rest period before eating and position the patient in an upright seated position in a chair or raise the head of the bed at 90 degrees. Have the patient flex the head slightly to a chin down position to help prevent aspiration. And if the patient has unilateral weakness, teach him or her and the caregiver to place food in the stronger side of the mouth. Then, feed a patient with dysphagia slowly, providing smaller size bites. Allow the client to chew thoroughly and swallow the bite before taking another. More frequent chewing and swallowing assessments through the meals are necessary. Allow the patient time to empty the mouth after each spoonful, matching the speed of feeding to the patient's readiness. And if he or she begins to cough and choke, remove the food immediately. Sometimes it is necessary to have oral suction equipment available at the patient's bedside. Moreover, provide opportunities for patients to direct the order in which they want to eat the food items and how fast they wish to eat. Determine a patient's food preferences and, unless contraindicated, try to have these items included on his or her dietary tray. Ask the patient if the food is the right temperature, and these may seem like small acts, but they go a long way in maintaining the patient's sense of independence. Patients with visual deficits also need special assistance. Patients with decreased vision are able to independently feed themselves when they are given adequate information. Identify the food location on a meal plate as if it were a clock. For example, meat at 9 o'clock and vegetables at 3 o'clock. Tell the patient where the beverages are located in relation to the plate. Be sure that other care providers set the meal tray and plate in the same manner. Patients with impaired vision and those with decreased motor skills are more independent during mealtimes with the use of large handled adaptive utensils since they are easier to grip and manipulate. Enteral tube feeding. Enteral nutrition, or EN, provides nutrients to the GI tract. This is the preferred method of meeting nutritional needs if a patient is unable to swallow or take in nutrients orally yet has a functioning GI tract. So, enteral nutrition provides physiological, safe, and economical nutritional support. Patients with enteral feedings receive formula via nasogastric, jejunal, or gastric tubes. Patients with a low risk of gastric reflux receive gastric. An enteral formula is usually one of the four types. Polymeric, which is 1 to 2 kcal over ml, includes milk-based blenderized foods prepared by hospital dietary staff or in a patient's home. The polymeric classification also includes commercially prepared whole nutrient formulas, and for this type of formula to be effective, the patient's GI tract needs to be able to absorb whole nutrients. So another way of feeding acute care patients would be parenteral nutrition. So in parenteral nutrition, or PN, is a type of specialist nutrition support that involves the administration of nutrients intravenously. A standard PN formula contains crystalline amino acids, hypertonic dextrose, electrolytes, vitamins, and trace elements. TPN is in a 2-in-1 formula that is supplied with central line and contains fat emulsions, in addition to protein and dextrose solution. Adequate nutrition needs evaluation, rigorous management of the central venous catheter or CVC, and diligent monitoring to prevent or treat metabolic problems are all required for safe administration. PN is given in a variety of places, including the patient's own home. To guarantee safe nutrition assistance, adhere to asepsis and infusion management rules regardless of the setting. So next is restorative and continuing care after acute care. So, medical nutrition therapy. Optimal nutrition is important in health and illness, but the specific dietary intake pattern that results in optimal nutrition is modified for patients with particular diseases. Medical nutrition therapy is the use of specific nutritional therapies to treat an illness, injury, or condition. MNT is necessary to help the body metabolize certain nutrients, correct nutritional deficiencies related to the disease, and eliminate foods that may exacerbate disease symptoms. It is most effective using a team approach that promotes collaboration between the healthcare team and an RD. So, the following sections address nutritional interventions for some common disease states. So, for gastrointestinal diseases, encourage patients to avoid foods that increase stomach acidity and pain, such as caffeine, decaffeinated coffee, frequent milk intake, citric acid juices, and certain seasonings, such as hot chili peppers, chili powder, and black pepper. Discourage smoking, alcohol, aspirin, and non-steroidal anti-inflammatory drugs. Teach patients to eat a well-balanced, healthy diet such as avoid eating large meals and eat 3 regular meals a day or several small meals without snacks, especially at bedtime. For diabetes mellitus, maintaining a prescribed carbohydrate intake is the key in diabetes management. So, a diet that includes carbohydrates from fruits, vegetables, whole grains, legumes, and low-fat milk is recommended. Monitoring carbohydrate consumption is a key strategy in achieving glycemic control. Limit saturated fat to less than 7% of the total calories and cholesterol intake to less than 200 mg a day. Also recommended are a variety of foods containing fiber. Patients are able to substitute sucrose-containing foods for carbohydrates but need to make sure to avoid excess energy intake. So patients with diabetes and normal renal function should continue to consume usual amounts of protein. For cardiovascular diseases, diet therapy for reducing the risk of cardiovascular disease includes balancing calorie intake with exercise to maintain a healthy body weight, like eating a diet high in fruits, vegetables, and whole grain high fiber foods, eating fish at least 2 times per week, and limiting food and beverages that are high in added sugar and salt. The AHA, or American Heart Association guidelines, also recommend limiting saturated fat to less than 7%, trans fat to less than 1%, and cholesterol to less than 300 mg a day. To accomplish this goal, patients choose lean meals and vegetables, use fat-free dairy products, and limit intake of fats and sodium. Cancer and cancer treatment. So the goal of nutrition therapy is to meet the increased metabolic needs of a patient. Enhanced nutritional status often improves a patient's quality of life. So nutrition management of a patient with cancer focuses on maximizing intake of nutrients and fluids, individualized diet choices to a patient's needs, symptoms, and situation. Use creative approaches to manage alterations in taste and smell. For example, patients with altered taste often prefer chilled foods or foods that are spicy. Encourage patients to eat small frequent meals and snacks that are nutritious and easy to digest. For HIV and AIDS, patients with HIV or AIDS typically experience body wasting and severe weight loss. The wasting is related to anorexia or stomatitis, oral thrush infection, nausea, or recurrent vomiting, all resulting in inadequate intake. So factors associated with weight loss and malnutrition include severe diarrhea, GI malabsorption, and altered metabolism of nutrients. Often the medications taken to treat HIV infection cause side effects that may alter nutritional status. Restorative care of malnutrition resulting from AIDS focuses on maximizing kilocalories and nutrients. Individually tailored nutrition support progresses in stages from oral to enteral and finally to parenteral. Good hand hygiene and food safety are essential because of a patient's reduced resistance to infection. Small, frequent, nutrient-dense meals that limit fatty and overly sweet foods are easier to tolerate. So patients benefit from eating cold foods and drier or saltier foods with fluids in between. So examples of nutrient-dense foods would be whole grains, low-fat milk and dairy, fruit and vegetable, beans and peas, lean meats, poultry and fish and eggs, and nuts and seeds. So, lastly is evaluation. Patients expect competent and accurate care. If ongoing nutrition therapies do not result in successful outcomes, patients expect nurses to recognize this and alter the plan of care accordingly. Expectations and healthcare values held by nurses frequently differ from those held by patients. Successful interventions and outcomes require nurses to know what patients expect in addition to nursing knowledge and skill. So, work closely with patients to determine their expectations and talk with them about their concerns if their expectations are not realistic. Consider the limits of their conditions and treatment, their dietary preferences, and their cultural beliefs when evaluating outcomes. Patient outcome. Care plans need to reflect achievable goals and outcomes. Evaluate the actual outcomes of nursing actions and compare with expected outcomes to determine if the goals are met. Multidisciplinary collaboration remains essential in providing nutritional support. Nutrition therapy does not always produce rapid results if you do not observe gradual weight gain or if weight loss continues. Evaluate the dietary EN prescription and determine if the patient is experiencing any adverse effects from medications that are affecting his or her nutritional status. Changes in condition also indicate a need to change the nutritional plan of care. So, consult multidisciplinary members of the healthcare team in an effort to better individualize this plan.